Welcome back to the channel. This week, we're going to cover one of the big chronic neurological conditions, Parkinson's disease. You will inevitably have patients in your practice with Parkinson's disease or Parkinson's related problems. So, let's start with the features. Parkinson's disease classically consists of a triad of bradykinesia, tremor, and rigidity. And it's a direct result of the degeneration of the substantia nigra, with most patients being diagnosed in their 60s. In terms of features, the tremor itself is classically of a low frequency and described as pill rolling, whereas the rigidity is often referred to as lead pipe or cogwheel in nature. The bradykinesia in nature is often presented as a difficulty in initiating movements, with a fixed arm swing or short stifled steps when seen on examination. These patients often have other physical features, with classic stone-like faces and micrographia or tiny handwriting. Unfortunately, Parkinson's patients are at higher risk of psychological features, including depression and even psychosis. These patients often have a disturbed REM sleep disorder and dysfunctional autonomic symptoms, such as postural hypertension, which you may even see on the acute take, urinary problems, and constipation. Diagnosis is often undertaken by a specialist movement disorder clinic or neurologist, with CT single photon emission or SPECT CTs often helpful to display destruction of the basal ganglia. Management. In general, management is often initiated depending if motor symptoms are predominant or not. If motor symptoms are, then levodopa is often started. If not, the choice is between dopamine agonists, MAO-B inhibitors, or levodopa itself. This is to prevent the more common side effects of levodopa-based drugs and to help extend longevity of treatment. Levodopa-based drugs are often administered in conjunction with decarboxylase inhibitors. This is to prevent the breakdown of dopamine outside of the blood-brain barrier. Such drugs include Sinemet or Medapar, which you may have heard of. A bit more information about the drugs. Levodopa often has a reduced efficacy as time goes on, and hence its delayed usage in those without motor symptoms or younger patients is preferable. Side effects, however, include dyskinesias, dry mouth, postural hypertension, and the classic on-off features. This is what often presents to us in general practices. Sudden stoppages of the drug can, however, cause a massive deterioration in the patient's condition. For example, if a patient is nilbar mouth for whatever reason, and thus alternative routes of administration should be sought, such as transdermal. Dopamine receptor agonists. These tend to be preferred in younger patients or those without motor symptoms, as it allows the delay of the use of levodopa. They tend to cause nasal congestion, exacerbate postural hypertensive symptoms, and can cause quite distressing hallucinations. Some of the older dopamine agonists, such as cabergoline or bromocriptine, have become quite unfavourable in Parkinson's disease due to the adverse effects such as fibrosis of the lung and heart. These have been superseded by newer generation dopamine agonists such as ropinirole or apomorphine. Some of the other drug classes include MAO-B inhibitors, such as razagiline. These need to be used in care with patients on antidepressants. Amantadine isn't used so often, but is particularly useful in dyskinesias. Antimuscarinic drugs like procyclidine are typically helpful to use in tremors, and COMT inhibitors like entacapone are useful to prolong the on symptoms and avoid the off symptoms when used in conjunction with levodopa-based drugs. Parkinsonism. We should also touch on Parkinsonism, which would include Parkinson's disease or any other condition that produces similar symptoms. These include side effects of certain drugs, such as antipsychotics, typically seen in long-term psychotic or schizophrenic patients. Multiple system atrophy. This encompasses Parkinsonism, cerebellar signs, and autonomic symptoms, including postural hypertension and urinary retention. Keep that in mind for the exam, because this is an often exam question. Progressive supranuclear palsy. These patients often present with neck rigidity or pseudobulbar palsy, with a poor prognosis. They often have ocular muscular symptoms, so that patients, when they're climbing stairs or moving their head in different directions, often fall, and there's some cognitive impairment as well. And Boxer's brain. This is also known as dementia pugilistica, from repetitive head trauma. Well, I hope that helps. You're bound to get a question or two around Parkinson's disease in your exams, and I hope this video gives you the comfort going forward. Check out our Instagram page, at Dorky_docs, where there's a ton of revision resources going out regularly, and our growing Facebook page and community. Make sure you leave a comment if you've got any questions or suggestions, but otherwise, like and subscribe, and I'll see you in the next video.